We're in the right channel. I just don't know
Okay,
why.
if everyone can mute, please, if they're making any noise. If anyone has questions, then unmute and interrupt yourself and whatever else. Okay, so sepsis in dentistry. Thank you all for coming this evening. Our aims and objectives. One is to define what sepsis is in our context. Two is, when do we consider sepsis? When do we think this might be a patient who's got sepsis? And three is understanding the sepsis screening tools, because it's not quite as straightforward as I think it could be. So, what is sepsis? Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. It is a major health concern and causes substantial morbidity and mortality. An evaluation of sepsis in dentistry, Dave et al. BDJ 2021. If anyone knows Paul Courtard, the former dean at the London, he was involved in this paper as well. So a shout out to the London Hospital. Sepsis is a subjective, clinical rather than a laboratory diagnosis, and recognition can be difficult, especially early in the clinical presentation when symptoms are non-specific and laboratory results are pending. That's come from the BMJ. And sepsis and antimicrobial stewardship are two sides of the same coin, is the name of that article. I think it's a good way of putting it. So yes, to definitively diagnose things, yes, you need lab diagnosis, but fundamentally we need to come up with sepsis diagnosis in clinic, or at least a differential diagnosis of sepsis. 80% of dental antibiotic prescriptions are estimated to be unnecessary. That's Wendy Thompson and all, antimicrobial stewardship in dentistry in the Lancet 2019. So it's a case of getting these two things balanced. Sepsis in the UK, according to the UK Sepsis Trust, we have 245,000 cases a year, so not an insignificant number, and 48,000 deaths. So roughly speaking, 1 in 5 people are dying of this. Now, anecdotally, people who deal with sepsis a lot tell me that sepsis is very much more common than that. And then, in effect, anyone with some sort of blood infection who's got fever due to a dental infection has mild sepsis. But when we talk of sepsis, we're talking about the more severe thing, the thing that can put you in hospital and kill you. So why are we talking about this today? Fundamentally, the reason we put this lecture on is because we had a case within one of our clinics. In April, a patient attended with dental pain, as many do, and he was seen by one of our dentists. The patient had trismus. The patient wasn't particularly unwell, but it was difficult to examine them fully. The patient was given antibiotics and told, if it gets worse, contact us, etc., etc., and nothing particularly unusual about that. However, within a few hours, that patient had contacted 111 again, and by that evening was found dead. The assumption being, and the coroner hasn't finished reporting yet, that the sepsis was of dental origin. The patient was 37 years old, a gentleman with no really severe health problems. He did have health issues, but he was certainly not that unhealthy. And it was quite unremarkable. Neither the dentist nor the nurse nor the receptionist had any recollection of this gentleman a few months later when they first found out what happened to him afterwards. And it's not anything to do with what these dentists did as such, maybe with hindsight, but without that, no. And what is interesting actually in this case is that everyone who's looking into it so far is looking into it in a way to try to learn. What can we all do better when we see someone similar next time? And that is for me, it's actually very refreshing, because when I get cases of a dentist who's, not found the mesiobuccal second root of an upper 7 or not quite got to the end of it, and everyone's complaining as if the dentist is incompetent and should never work again. Well, here we've got the way it should be. We're trying to learn from this. We can all get better. We can all think of this more. What we don't want to do is to see our patients this evening, and we've got 10 patients booked in, and 9 of them get carted off to by ambulance because we're worried about sepsis, and nobody actually gets any dental treatment done. Most of our patients, I mean, we'll come to this. Sepsis is a very big issue, but it is not what we're seeing every day. So when should we consider sepsis? The patient looks unwell. Okay, they all look unwell. The parent is concerned. If you go to the parents of the kids at my school, they will all be concerned. And the physiology is abnormal, their breathing difficulty and all that sort of stuff. But it's difficult to really put a finger onto it as to exactly when you should start looking at sepsis. You are highly trained dentists and dental nurses who are, for the most part, experienced in providing urgent dental care. Some of you might be new, but fundamentally, you've all got a lot of skill, a lot of experience. You see lots of patients. You've seen thousands of patients, some of us. You know who's a bit more unwell than just a bit of toothache and hasn't slept last night. But you may not get it always right. And the doctors in the hospital don't get this right every time. And they've got all the, all the tests going. Most of our patients require dental surgery. They don't require sepsis care and they don't require medication. They require extractions, extirpations, incisions, whatever it may be. They've come to see you, and that's the dentist, and they come to see the nurse as well, and the receptionist. But fundamentally, they've come to see us, not someone else. So fundamentally, as much as possible, we need to do something for these patients. If we take that tooth out and drain the infection away or drain the disease away, the problem's gone. Now, sometimes we can't deal with it. Some things are way beyond our abilities. Nobody would ever expect us to try and deal with it. But some things are not. Some things we should try and do what we can to get patients out of pain and try and encourage the patient to accept that they need to be got out of pain. Okay, moving on. So, has anybody here seen a confirmed sepsis case in their surgery? If anyone wants to unmute and say, yeah, I saw one.
Not in surgery, but I realized later that they had because they actually called in.
Who's speaking here?
Oh, Fatima.
Fatima, thank you. So what, they called in afterwards and you realised it was sepsis. So what did you do?
So they came in. I went through my notes and I had done all the things that I would expect to do. So there was no swelling. There was no obvious sign of sepsis at all. The patient had just a little bit of pain, and very vague symptoms, but we did an X-ray, no apical radiolucency, literally nothing to indicate me actually do an extirpation or any intervention. I said to the patient, look, I can't actually see any apical radiolucency to carry out an extirpation. There isn't any evidence of it. There's no evidence of fracture. I went through the list of things that could possibly be. Anyways, we removed the filling that he had because it was cracked. There was no decay underlying within it. We put a temporary filling in it, and then a week later, he emailed saying that that tooth needed to come out. They X-rayed and found that it was the cause. And the thing is, on my X-ray, it didn't show any apical radiolucency. It didn't show anything, and that tooth was then extracted, and he was in hospital for about 3 days. And then my boss went through my all my work, and she was like, I on the X-ray as well, it didn't show anything. I was actually really surprised, and I thought I took a thorough history, so I actually happened to be recently. That's why.
Thank you for sharing that. Has anyone else actually seen a confirmed case? No, the answer is there's not a lot, but we've got to be aware of it. I've got to say I've personally seen cases that maybe they were. I've sent people to hospital and not heard back. I've had someone go to hospital. I spoke about this case some years ago, where they went to hospital afterwards. There was never any proof they had sepsis, but who knows? Moving on. So, how many of you know what PWS is? Pews. I'm not sure if it's meant to be pronounced as pews or it's PWS. right? And please, nobody knew that, because if you did, I'm in trouble. I'll come back to it later. The sepsis screening tools, these are the red pieces of paper you see up on the wall, the red posters. Most practices should have this, certainly our practices have got it. And they are nominally designed for dentists and dental nurses. On the top of one of them, it says follow pews, as if like we're meant to know what pews is. The five of them are children under 5, children 5 to 11, children 12 to 15, adults and pregnant ladies up to 4 weeks after giving birth. It used to be one for adults, one for children, so it's changed. There's 5 different forms. No, there's 5 different forms. That's an important thing that you're aware of. So when you go to the sepsis sheet, when you've got a patient who you think's really bad, you go to the right sheet. You're aware there's different sheets there. So these are the sheets that there are. We have one here for adults, one here for children. I can't actually see the top, and it says here, if concerned or physiology is abnormal, e.g. pews, as if a dentist is meant to know that. Now, pews is, I think I looked this up, and it's you go into hospital and they've got on the bottom of the bed this chart that they keep measuring. Well, that's what pews is for children. It's a measuring system they have. Okay, so you go to the thing, you go to each section of the form, and we're going to go through it in detail now. These are the tools that we have available within the clinic. You've got those sheets, you go to the sheets. It is the responsibility of every dentist and every dental nurse to know where the emergency drugs and equipment is kept, even if you only work an occasional session at the practice. You'll have been told when you were inducted, but have you remembered? If you don't remember, ask. Go ask somebody, find out where it is, look around, know what's in the building, know what we've got. It's the responsibility of every dental nurse and dentist to know how to use them. So there's no point saying, yeah, we've got a DFib, but I don't know how to use it. You must have annual training in basic life support. And if you need help with any of these things, ask your service manager, Joe, Lisa, Leanne, me, Angie, whoever, agent. Ask for help, because none of us know everything. But this is something that when it happens, you need to know what you're doing. In an emergency, typically speaking, you've got a dentist, you've got a dental nurse, you've got a receptionist out there. The dentist takes the lead for their patient. Obviously, in an emergency, it could be the dentist that's keeled over, in which case someone else takes the lead. Drugs and oxygen. So we've got the medical emergency drug kit, we've got oxygen. It used to be, they said to you, use maximum supply of oxygen. What happens if you know the ambulance is going to take an hour to get there? You need to be aware of how much oxygen you've got in the building and how long the ambulance are going to come. And there's a table up of how you titrate it, how much oxygen you actually give so you don't run out of it. It's not ideal, but it's real world. However much oxygen there might be, there's not always enough.
Mm.
Yeah.
You're fine. Oh, careful, Baba. Sorry.
Sorry? Is that a question?
Oh, sorry.
Okay, fine.
Somebody's got their
Someone, could they mute themselves? They've got kids there. Right, there's a defibrillator we have. Know how to use it. They're meant to be idiot proof, but they're not. A thermometer, they go on the head. Pulse oximeter goes on the finger. Blood pressure monitor goes around the arm. These are not difficult things to use, but you should have some knowledge of how to do it. And in front of the patient, the patient's family don't think you're an idiot when you're trying to work out which way round it goes. So, you go to the top of the sheet. We're going through the adults one. I'm not going to go through all of them, and you don't need to learn this. You don't need to remember it, but you've gone through it once. You've got some knowledge of how it works. Start this chart if the patient looks unwell. So what are the risk factors? An elderly patient, a patient with impaired immunity, someone who's recently had an operation, that's many of our patients, an invasive procedure, an indwelling line, or an IVDU, intravenous drug user. I mean, that's there for children as well. So I don't know how many under 5s are IVDU, but whatever. Under 5s, yeah, still IVDU and this Pews thing. But fundamentally, someone who's very ill, but think of it more if they're very old, if they've got impaired immunity and they've had trauma or they've had recent surgery. Could this be an infection? I'm not convinced that's, each of these are slightly different. Each of these 5 pages are slightly different. So that's why you don't want to learn it, because you won't remember it, but just know to go to the right one. This section, number 2, I don't think is overly helpful, but you got to look at it. The next sections are critical, and again, they're different for each age group and for each, adults, pregnant ladies, etc. And say, don't try and memorize it. Are any red flags present? So, objective evidence of a new or altered mental state. Do they look like you don't know where they are? I recently dealt with an emergency patient. He'd fallen off his bike and cracked his head on the street. When I got there, he was just about rousable if I shouted at him. One stage more is you have to actually push them or pinch them to get them to respond. By the time the ambulance arrived, he seemed to be in a normal state, although he was the sort of person you couldn't really tell if he was in normal state or not. I don't know, maybe he was normally very articulate and was coming across as a bit daft, but I don't know. Respiratory rate, more than 25 a minute. You can spot it. You don't need to measure it, but you can spot it. Oxygen, need for oxygen to keep their oxygen saturation at more than 92%. Most people are running at about 98, 97, 99 at the moment. Systolic blood pressure, I'll come to that. Heart rate, I'll come to that. Not passed urine in 18 hours. It's a red flag. I thought it was a brilliant question, but when I ask people who see sepsis a lot in hospital, they say you'll only spot it if the patient's got a catheter in. They go round the beds. Everyone's got a catheter bag full of urine, except the guy with sepsis who's got an empty bag. A rash, I'll come to that as well afterwards. If you see one of these, you phone 999, you say red flag sepsis. They will get you priority. Right. The mental state is not easy to determine, as I said. Tachypnea, fast respiratory rate. Count it, time it. You don't have to count a whole minute. You'll see it's quick. Oxygen saturation, put the batteries in the pulse oximeter and place it on the finger. The battery should be left out, because if we're not using it every day, when you go to use it, you want it to work. Blood pressure. The blood pressure drops low in sepsis, so their systolic blood pressure will go down low. How accurate that is, I don't know in general practice. I know if you're in a hospital and they take your blood pressure every couple of hours and they see it dropping, they can see there's a problem. But systolic rate is the top one. 120 over 80, it's 120 we're measuring. If that is below 90, there's a problem. Tachycardia. Stick your finger on the patient's pulse, on the patient's carotid artery, and feel for the pulse. Count it. Count your own now. See what it feels like. Not past urine. I said it's an awkward question, but it's an easy question to ask. And you tell them why you're asking it. How useful? Don't know, but we're supposed to ask. A rash which doesn't go away when pressed is a problem and something we need to be looking for. So I picked this picture up from the BMJ. This is what a sepsis rash looks like. Well, yeah, it's fairly clear, isn't it? I don't know, just about. However, most of the patients that I see in practice, I expect most of you see, attend with their clothes on. I'm not convinced I see that. I mean, yes, I can see it when I'm looking for it, but would I spot it if I wasn't looking? Maybe not. I don't know. The whole point is sepsis is difficult to diagnose, and we've got to be aware of it. So we've looked for red flags. We haven't seen red flags. We're looking for these orange flags next. The thermometer. These thermometers, we picked them up during COVID. They go on the forehead. They're quick and easy to use. I'm not sure how accurate they are. So if we measure ourselves first, the way I do it in practice, I measure myself, my nurse, and then the patient. Or the nurse measures herself, me, and then the patient. The clinician's temperature should be normal, as we don't come to work when we've got an active infection anymore. We used to. So we shouldn't be coming into work with fever. If I'm, whatever my score is, if the patient's a bit higher, that means they've got fever. If the patient's a lot lower, which can happen, that's also an issue with sepsis. If they've just walked in and they're freezing, it may be difficult. If they're just running because they were late, again, they might be difficult. But we have to use our judgment. Know the medical history. So, where are we at before we start treating a patient? And that medical history should be recorded in the medical tab on Dentally. Why? Because everyone else needs to know where it is, especially if the patients come back. If we have one of these, it says here, use your clinical judgment to determine whether the patient can be managed in the community setting and consider secondary assessment, bloods, and follow up with their GP. You know what? I would probably still call 999 if I've got an orange flag, an amber flag, they're calling it. Maybe I'd get them to call 111. Depends on the case. Yes, use your judgment, but vie on the side of caution. However, we're dentists, we're emergency dentists, get drainage wherever possible. We come back to that. You know, don't just tell them to go speak to their GP because you might have sepsis or 111. We need to be seeing them. We need to be dealing with the underlying problem wherever possible. We have this sepsis mnemonic. Consider sepsis, dial 999 if they have slurred speech or confusion. Could be drunk, but you got to look at it. Extreme shivering or muscle pain, passing no urine in a day, severe breathlessness. They're saying things like, I feel I might die. Their skin is mottled, ashen blue, or very pale. Move that away. So our note templates. All right. So that's basically everything there is about sepsis. Does anybody have any questions? As ever, you can put questions in the chat. You can phone me later if you've got questions. You can send me emails. A couple of other things I want to go through while we've got a big crowd here, which are not specifically sepsis. The note templates. Every patient that you see on an HUDC session should have the note template used for the examination. Almost every patient. There may be some where you've got to do something slightly different. Dentists, please use it. If you don't know where it is, please ask. Nurses, if you see the dentist and not using it or using other templates or whatever it is, tell them to use these ones. It's a problem if you're spending 3/4 of an hour writing up a whole load of notes and not seeing the patient. The patients need to be seen and you need to get the right things written down. The templates are there to remind you what to write and what to check for. The drop-down list. This is where you write down what the diagnosis was, what the primary treatment was, did I give antibiotics, and if so, why? This needs to be for every patient, including patients who are not urgent care patients. Every patient you see, this needs to be filled in. We use this for the audit. If you're only doing it half the time, we can't really audit properly. The number of people filling this in every time is improving month by month. But can I remind you, please, to do it again? Nurses, if you see the dentists aren't doing it, tell them please do it. Necessary care.
Scott, so to jump in, I love you also to be familiar with that template. So if you have a new dentist, if you know how it works, then it's twice likely to get done. So if you see it not being done, especially if you regularly do it, the dentist might be less regular than you say, no, this is where it is. Because remember, when we want to look back at things, if it's all in one big long 3.5 page, essay, then we can't find what we need to find, either colleagues or us from looking at things.
I would say it's professionally inconsiderate if you write 3.5 pages of notes for a 2-minute appointment and expect your next colleague to have read it and understood what's in the middle of it. You've got to write the right notes, but there is a limit to it. The next one is to say the necessary care, the drop down list, there's also guidance on it. If you're not sure, ask your service manager for the guidance page on it to know what to use, when to use it. Necessary care. We see a patient for urgent care. They haven't got a dentist. They can't find a dentist and they've got other problems. They need to be offered another appointment. And there's a system for it. You've got to fill in the paperwork for it for every patient. We need to be doing this. Some of you will notice that your book's half booked. If you want the service to remain viable and the systems to still be here for patients who need it, you need to be booking patients that need it back. And again, there's guidance on it. If you don't know all the guidance, please ask. Peer mentoring. We've started this. We've had the odd dentist has started doing this. Let your service manager know when you want to be observed, or if you want to observe me or any of the other senior dentists. The aim of this is we're going to improve. We're going to get more consistent. We're going to find little things that we're doing that we could do better. Hopefully not too big things, but if we find big things, great. We'll find them now rather than later when there's a problem. We've all got to learn. Every one of us is going to improve. All surgery referrals. If a patient comes in and has an extraction that needs doing, we all want to try and get better at this, to try and improve the number that we can do. Sometimes giving it a try is a good idea. The patient's in pain, they've got an active infection. If you try and fail, at least you'll get somewhere. You'll have done a posh extirpation by taking the crown off or whatever it is. If you can't do it, obviously you've got to refer it. If you're in Hertfordshire, you've got to refer it by, dancing around the room and making 7 different phone calls to 6 different people, and it's different on a Monday to a Tuesday. Unfortunately, they need an OPG, whether they need an OPG or not, whether you've got an OPG or not. It's made to be difficult sometimes. Unfortunately, we are setting up a system whereby if they're difficult, we're going to refer them in house. Any dentists who feel they can take some of these patients on, please let me know, or let Lisa know, or let Joe know, or Leanne. But we're trying to make it a bit easier, both for the patient, well, specifically for the patient, but also for the dentists that are finding it difficult to do them. But the quid pro quo is try and get better at doing them as well. We don't want you suddenly saying you can't do anything. We're just going to refer it in house to another dentist another day. Thank you all for coming. I think it's important that we remember the reason we're here, and that unfortunately, a young patient passed away, and to understand that we can all learn and we can all try and get better at this, so that in future we can, deal with problems and hopefully don't get the same thing happening again. Any questions? Brilliant.
One last comment in terms of referrals. Sorry.
Go ahead, Adrian.
So in terms of what we want to try and do is have a like tier 1.5. So something which is definitely needs referral. We like wisdom teeth with it on the ID nerve, we still refer. Everything else we try at least do some the moderate ones in-house. I would also say in terms of referral, I think Scott might have mentioned it, we need to charge them a band 2. That we certainly in London, the head honcho of the NHS London said it's a band 2. Those are the NHS regs, and it's probably true. It's 75 quid. It's more money than 25 quid. I get that, but you got a specialist doing it. It's 75 quid. We've still got to work out what happens if it's tier 1.5 in-house here. Do we charge them again 25 quid? Our hunches we do.
Yes,
but
there's a flow chart for it when it comes out. We've been piloting it in Rickmansworth. When it comes out, everyone will see the flow chart of when you charge, who you charge, what you charge. Obviously, assuming they're not exempt.
Yeah,
but we've got a flow chart for it, and But also, if you've got a patient you're not sure about, there's more than one dentist in the building. Speak to him or her. Ask their opinion. Maybe they could take it off you straight away. Maybe they could help you with it. If you're struggling with that, there's a rota of myself, Adrian, Hummer, and maybe Sarah that you can call of an evening. Obviously, send us a WhatsApp or something of the X-ray confidentially so that we can help. We know what we're looking at, but maybe we can give you some advice on it as well. To try, the patient that's turned up, they want it done there and then, but obviously it's not 100% possible. A couple of other housekeeping points. If you haven't already, if your name is not clear on this register, please put your name and GDC number in the chat. If there's more than one of you watching on that terminal, put your name and number in the chat. For feedback, if anyone's got any feedback on this lecture, if they've got questions about it, if they've got complaints about it, or specific requests for further lectures or times, please send that information to your service manager, and you will get CPD for being here. We'll send a certificate to you. If anyone hasn't done their feedback for the other lectures they were at, please send your feedback form to get the CPD. I'm going to end the recording here.
At some point I waited in the car.